Hello, my name is Will Warburton and I'm Director of Improvement at the Health Foundation. I'm going to share some of what we've learned from our work in terms of spreading improvement. But I thought I'd start with a painting. Many of you will recognise Girl with a Pearl Earring, painted by Vermeer in 1665. And some of you may recognise The Supper at Emmaus. This was purchased by a famous museum in the Netherlands in 1937 as a newly discovered Vermeer which had been lost for 300 years. Only it had actually been painted the year before by this man, Han van Meegeren. Van Meegeren sold millions of dollars worth of brilliantly executed new Vermeers, including one to Herman Goring and one to the Dutch government. Yet despite his incredible talent, relatively few people have heard of him, and his posthumous reputation is at best mixed. So when their paintings are equally beguiling, why is Vermeer a genius and Van Meegeren remembered only as a convicted criminal? Because we prize the inventor, not the imitator. We heroise originality, and we're often derogatory about those who imitate or follow. And yet we know that if the least productive NHS organisations were as productive as the most, would be a long way towards the £22 billion worth of efficiency savings that are required. If the safest and best care that we deliver was the care that we deliver to all patients every day, then we'd be very close to the quality of care that we want to see. So spread and adaptation of what we already know matters, and it matters a lot. The Health Foundation has supported hundreds of improvement projects in the NHS over the past decade, and a selection of the programmes are on screen. So within our portfolio we have programmes such as Innovating for Improvement and Shine, which give £75,000 to teams for 1-year projects to test innovative ideas at the front line. We also have a strong commitment to supporting the diffusion of what works, and programmes such as Scaling Up and Spreading Improvement put larger sums of up to £500,000 to support teams to spread proven innovations. So based on the evidence arising from these programmes, I'm going to say a little bit about what we've learned, about what gets in the way and what supports successful spread of improvement. So firstly, what gets in the way? Well, we evaluate all of our programmes, and our experience reflects that described in the literature. Spreading improvement is hard work and variable in its effectiveness. Effect sizes in terms of spread tend to be either 0 or only 10 to 20% of the original impact. And why? Well, multiple factors. A fragmented healthcare system with many individual providers coming up with their own solutions, short-term planning cycles and financial incentives that encourage short-term thinking, coupled with a not invented here mentality as described earlier that prizes originality over adaptation. And I would highlight one key further insight from our evaluation of the Matching Michigan programme in a document called Lining Up by the University of Leicester. Now, Matching Michigan was the NHS's attempt to replicate a highly successful programme to reduce central line-acquired bloodstream infections in the US, in Michigan. The evaluation showed that the intervention had less impact in the UK than in the US for a number of reasons, including different implementation mechanisms and approaches to change. For example, the NHS programme being more top-down rather than clinician and peer-led. And the evaluation includes this quote from the theoretical physicist Richard Feynman, which I think deserves reading in full. It says, "In the South Seas there is a cargo cult of people And during the war, they saw airplanes land with lots of good materials, and they want the same thing to happen now. So they've arranged to make things like runways, to put fires along the runways, and to make a wooden hut for a man to sit in. And they wait for the airplanes to land. They're doing everything right. It looks exactly the way it looked before. But it doesn't work. No airplanes land. So when spread initiatives are implemented without understanding the real factors that made them work originally, they risk becoming imitations that reproduce the outer appearance of the original program, but not the mechanisms that produce the outcomes in the first instance. Just as in the case of this quote, it was the war that meant that the planes had caused to pass the islands in the first place, not the existence of a runway or men sitting in a wooden hut. So, there is no substitute for deep and meaningful engagement and examination of what made an original idea successful before attempting to spread it. But the good news is, there is also an evidence base for what works in terms of supporting spread. Based on a scan of 477 empirical studies, Dr. Deborah Da Silva and colleagues produced this evidence scan, Spreading Improvement Ideas, which is available on the Health Foundation website. And in summary, it shows what can support at local, regional and national levels, whether that's targeting individuals, recognizing that relationships, culture and structure are important, targeting senior leaders, managers, others who can help with dissemination, or at least not hinder, providing focused and proactive training on the innovation, particularly approaches that involve active components and follow-up, team-based training, particularly strong evidence base. Internal marketing, meaning the ways in which the innovators and others who are helping to spread the improvement tell the story of the organisation and how this effort fits within it. Equally at a regional level, drawing on when they draw on peer support and the power of personal, professional networks and relationships, collaboratives can help build a coalition for improvement and motivate others to act. Where they do work, they harness existing networks. These could be professional networks through Royal Colleges, peers, training rotations, or just as likely through informal networks, with the theory being that it's that kind of social influence that bridges the gap between knowledge, being aware of something, and actually taking action on it. And that can be buttressed and supported by good use of social media to share information, provide peer support through any program. And then nationally, many of the same interventions writ large, targeting key decision makers with relevant data, concise argument that fits their agenda, using networks and embracing larger social marketing campaigns. And the evidence scan also offers 10 tips drawn from the empirical evidence aimed at practitioners that may be useful if you're thinking about designing for spread when beginning your improvement efforts. I'd highlight in particular these ideas of getting a range of people involved and empowering them to participate in the dissemination and leveraging professional motivations to encourage the spread. So there are things that we know, there are things that can be done, and after all, like Han van Meegeren, creative and talented people, such as those who work in health, have always created and borrowed, imitated and improved, and when that happens enough, the results can be quite impactful. Thank you.